Hey, got some requests to talk about the surgery, and there's a couple things I want to do in this. Now, look, full trigger warning, these are graphic. So if you are sensitive, this is not for you, right? But this first part is for you. So first and foremost, I just want to reiterate a couple things. One, we never treat the scan. You are not your MRI. You're not your radiographic evidence. We know that the human being is very, very competent at handling degenerative changes. Now, a question about how much degenerative change is normal or how much what our behavior or lifestyle or movement quality generates that, what are the components of our genetics that implicate, discopathy, OA, all of those things aside. But most importantly, just remember that what I like to tell people is like, look, the reason we have an MRI, the reason we get these radiographs is we're thinking, hey, we've cleared everything else off the table, and now it's time to see if surgery is the option because there's something that we can improve around the physiology, right? So that's the first word. And the old phrase is we treat the man, not the scan. That just rhymes. We treat the person, not the scan. I think that's really the key here. Second is that we never, ever, ever get people into the mindset of, seeing a picture of themselves and not relating that back to their function. So remember, we're not talking about impairments of the tissues, right? We're gonna see impairments of the tissues. If you cut everyone in half and did some really interesting live person autopsies, you'd see herniated discs, you'd see stenosis, you'd see osteophytes, you'd see degenerative changes in the tissues, and those people would be pain-free and setting world records. So, because we know that's the case. So keep in mind, once again, that what we tell people is, hey, you have a white ball of light, and those joints are shiny and perfect, and until you have crossed everything else off the list, that's not the problem. Lastly, I just want to reiterate that, in this situation, I injured myself with some trauma skiing 7 years ago, going very, very fast, booted out, and had 2 kissing bone lesions result from just sliding and having my femur impact my tibia. So that was the original sort of mechanism of high energy trauma that happened to my knee, and no amount of mobilizing or strengthening is going to get me around the trauma to the tissues, right? I have a running on a flat and a bent rim, and it just doesn't matter how well I drive. I can normalize or optimize my surfaces, optimize my tissue healing, but I can't get around some of these implications. So what I want to show you is what was going on, and I also want to make the case for why we treat swelling so seriously in the body. Now, I was at a course recently, or at a conference at the Sparta Center for Performance down in sort of south of here in San Francisco South, in the South Bay. And a physician gave a great presentation just basically talking about one of the things that happens when there is trauma inside a joint around ACL injury specifically is that cocktail is really actually very noxious to the inside of the joint. It sort of accelerates degenerative changes, which is something that we're trying to work on. How do we minimize sort of that swelling cocktail, that trauma, that joint damage issue in terms of what happens for the next 50 years. And the research was that basically if you have an ACL injury, likelihood of you having your knee replaced at some point in your life basically goes up by 50%, which is a really interesting idea, which is one of the reasons, again, why we try to take swelling of the joint seriously. It doesn't mean it's emergent, we need to manage it today, otherwise your knee will fail to load or fail to thrive, we see that people kind of mess around and flirt with degenerative changes in their joints for a long time in the form of swelling, and that makes a less robust surface. So you've had the trigger warning. Keeping in mind, lastly, that one of the things that I want to get through here is that when we have surgery or a broken bone or something happens, we always tend to look at that feature. And let me give you an example. My daughter, Georgia, when she had that catastrophic spiral fracture a few years ago on the trampoline, right, the doctor, took the cast off. She's like, she's good to go. And I was like, what do you mean she's good to go? Like, what attaches to her tibia, sir? And he was like, everything? And I was like, yeah, everything. So we never ever just want to look at the bones. So it's great here because you can see this is my tibia. Now I have this beautiful implant with a disc, a 5mm disc, and this is my femur with a brand new shiny head. What you're thinking to yourself, we gotta let those bones heal. But there's a little bit more to the story. So if you're squeamish, look away. If you want to look at what the inside of my knee looks like, hold on to your butt. So here we go. Let me show you what the first photo looks like. And what I want to talk about is just orient yourself a little bit. So this is the tibial plateau. And so when I went and put my femur in at that high speed into my tibia, or tibia into my femur rather, one of the things that happens was that I had a bone lesion on that back side. And you can see this. This should be smooth on the other side, and that's a pretty gorgeous, this would be my medial tibial plateau, as in this inside, and this is the lateral. So this is the back lateral where I felt like my trauma. So your medial side is mainly your main weight-bearing side, but of course you're weight-bearing on both sides. But I want you to understand that you can see how far that translates forward. You can see the sort of the remnants of my ACL and PCL there, which have been cut during this. But what I want to show you first and foremost is that, wow, look at the amount of junky, ugly kind of tibial plateau trauma here, and I didn't have a meniscus. So when we went in there, the surgeons were actually shocked at how bad the inside of the knee was. So here's another angle showing a little bit more height to this, and you can see the disc, the sort of semoid, the platform there, and it creates a beautiful space, and the meniscus is there, and it helps to centrate the femur. And on this side, that's not healthy bone. That is ugly, ugly, ugly bone. Again, ACL, PCL. But what's interesting again is that, I was able to handle positions where I didn't have symptoms, I didn't have loss of force production, I didn't have grindy feelings. And last year I was able to pull 605. About a few weeks before this, I pulled 500. And what I started to feel like is, my body doesn't like to compensate. It's not appreciating that generating force. Last year, I ran a half marathon with Juliet. We did the Spartan half marathon, and I had a real hard time finding a position where I could run and absorb force. Push pressing was out, squatting was out. And what was happening for me is beyond the impairment or functional limitation, i.e. I changed my movement pattern, was that I was suddenly not being able to do things like play with my family. I'd ski for an hour on soft snow, but it was hard pack, icy snow, man, I was good for an hour and I'd go sit in the car. I started having to paddle goofy instead of regular foot on my stand-up. I would have to be, we were gonna throw a Frisbee, I'd be like, ooh, okay, I'll have to take some ibuprofen after this to manage some of the feelings. This summer I was carrying my boat on a portage during a round of class 5, and I had to step down with my boat, and I felt like my knee almost gave out and I almost fell to my death into a class 5 rapid. So again, the reason I ended up pursuing this after talking to 4 surgeons was I was at a place where too many things were coming off the table, and I want you to be able to see why. So now moving forward, what I want you to see is that this is my femur, so you can orient yourself. And this is this aspect of my femur. This is the lateral side, right? And what you can see, this is my right leg. So you can see that I have a gigantic lesion on the femur as well. So the problem was I didn't have just a lesion on a tibia, and I didn't just have a lesion on the femur, I had lesions on both. So I had kind of an imperfect surface. And I had no meniscus in there. So meniscus transplant out. The femur sort of, stem cell magic, hope these cells go in here and differentiate into a rebuilding out. That's not possible here. So what was possible was trying to get into the best positions I could with the healthiest tissues I could have, and then managing my movement. And once again, I didn't have a whole lot of pain. In fact, they were really shocked at the trauma inside my knee and my function and low level of pain. So waiting around to let pain decide movement is like saying, hey, I'll just keep squatting this way because it doesn't hurt, right? And versus, hey, what's the best expression of the human movement possibility? How we teach to the highest expression of the movement quality? And that's why it's so important that we're looking at our best movement practices around gymnastics and Olympic lifting and powerlifting and track and field, and using those models, those movement models, to really say what is the best expression of human physiology. Not, I move this way and I did a lot of exercise and then suddenly it hurt, so I changed something, right? So what I want to show you here is the case so I can orient you again. That's the top of my femur there, where my kneecap is rubbing. And you can see that I have a gigantic lesion where my kneecap was rubbing in here. And that's not because I had a patellar femoral problem. In fact, I had zero pain in this compartment. But what ended up happening is I had such a junky, swollen, unhealthy knee for so many years, over half a decade, that femur, that patella started to wear a hole into my femur. And so again, one of the reasons that we're not trying to catastrophize and say, hey, look, you need to manage the swelling, but hey, we take swelling seriously because when a joint is swollen, we see downregulation in function, we see poor healing times, we see proprioception being altered, right? The person and the brain don't the body and the brain don't interact as well as they could when the tissues are really, really effused. And then finally, I just want to show you a couple things. So you can see that they basically ran this incision up, went around my kneecap, and if I hold this down, let's see if you can see some of that motion in there. There's a lot of movement into the knee. So I like to have been saying, like you could basically birth a person out of my knee there, and no wonder I'm a little bit sore at the top, right? Because everyone's looking, hey, the bones are great. Basically, I have a new surface on the back of my kneecap, so I have half my kneecap is removed. I have my femur resurfaced and my tibia resurfaced, but just look at the amount of movement into the system here, and that is part of the reason why we have to take sort of the tissue healing seriously around the whole system. We're not just looking at waiting around for the bones to heal, but really appreciating that there's a lot of soft tissue trauma that I have to go through. So if I sprain my ankle, we would know that, hey, a bad ankle sprain is going to take 4 to 6 weeks to heal, right? It doesn't matter how clever I am, what tools I use, the maximum rate of healing is going to be between that 4 to 6 weeks. Pain may drop out long before then, but that 4 to 6 week healing cycle is going to be part of the game. So imagine now that I have basically been in a car accident with my knee, and no wonder I'm 3 weeks in, I still have some pain when I load, it doesn't feel really great, I have some tissue stiffness, and I just want to reiterate that one of the reasons that we're looking so much at how well the tissues are sliding, what's going on with the swelling in the local tissues, because there's a lot of trauma to that system. And then here I just wanted to show you quickly that you can see again the tissue spread here as they've created enough space for them to work, including movement of that tibia or that capsule onto the tibia and onto the femur. So there's a lot of capsular strain here into the joint capsule. This is my actual femur, and you can see that they've shaved it down so that the cap can go on. But once again, what the heck is going on? There's my patella off to the side, right? So we've got to be cool in terms of we're moving. So I'm moving very slowly and very deliberately and making sure that it doesn't feel bad. And then I just want to show you that there is a beautiful view of them tapping in and setting that gorgeous, brand new head of the femur. So shiny. You can see that the tibial plateau has been mated, and then there's the poly disc, the 5mm disc in here, which is going to act as my meniscus. But once again, look at what's going on around the other tissues and the number of times they took me into extension, lateral motion. No wonder my MCL is strained. If I took your MCL and just flexed your leg back and forth a whole bunch of times to the limits of its movement, especially when the leg wasn't encapsulated, you would have a sore MCL too. So again, bottom line here is to think we want to make sure that when we're dealing with trauma, that we aren't just looking at bones, that we're always thinking about soft tissues as well. Sliding surfaces, hydration, desensitizing, reperfusion, right, decongestion. We never treat the image of someone's knee or disc or tissue. We always look at their function and how that relates. We always assume that, hey, the body can buffer those things for a long time until it can't. And if we've controlled every other thing that we can control, sometimes we can't manage tissue trauma any further. And then just keep in mind that you are designed to go 110 years, and sometimes when you're skiing very, very fast and we have trauma, this is the result. And this is the only way out of returning function. So not letting pain be the driver, but letting our function be the driver. Again, hope that didn't gross you out too much. Time for a warm tuna milkshake. See you next time.